Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, the host of Paincast and an executive member of the Pain Science Division. I'm a physiotherapist in Toronto. This episode is another one where students get to host an episode. I mentor physiotherapy students at the Pain Science Division Student Committee to develop episodes on a topic of their interest. It's a year-long project for these students, and they worked very hard to deliver top quality and evidence-based discussions for you. I will let Maya and Rebecca take over from here.
I'm Maya, a physiotherapy student from University of Toronto.
And I'm Rebecca, and my physiotherapy background comes from the University of Alberta.
What are the gaps in our healthcare system in managing pain in Indigenous peoples? What are some underlying causes for this disparity across lived experiences of pain? What does it mean to offer care that honors not just the body, but the history, land, and culture that affects an Indigenous person's experience of pain? We had the great honor of speaking with Dr. Jaris Swidrovich about these ideas.
Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests. They do not constitute medical advice and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. Enjoy the episode.
Hi, Jaris. Thank you so much for speaking with us today. So before we start, we'd like to pause to acknowledge the land on which we are calling in from today.
So I'm Rebecca. I'm calling in from Edmonton. I live near the University of Alberta, which is located on Amisk-Watsky-Watsika-Hegan on Treaty 6 territory, and that's a traditional meeting ground and home for many Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, and Inuit peoples.
Today, we are joining you from Toronto, which is the traditional land of many nations, including the Anishinaabe, the Chippewa, the Haudenosaunee, the Huron-Wendat, and the Mississaugas of the Credit. And we're grateful to live and meet today on these territories. So, Jaris, do you want to tell us where you're calling in from today?
Yeah, you bet. So I'm also calling in from Toronto, or Treaty 13, Dish with One Spoon territory. But similar to Rebecca, Treaty 6, which extends to Edmonton, is my homeland where I've spent most of my life, although my reserve is Treaty 4 territory. So 3 different territories I'm involved with, but calling in from Takaranto, Toronto.
So again, thank you so much for joining us. We're so grateful to you for taking the time, and we're super excited for our discussion today. So firstly, how are you doing?
Great. Yeah, thanks for having me.
Yeah, we're so excited. To start off, can you introduce who you are, what you do, and what a typical week looks like for you?
Oh, geez, sure. So my name is Jaris, just like Paris, and last name is Swidrovich, and that's my Ukrainian side. So my dad is entirely Ukrainian. On my mom's side, I am Saulteaux, so like Anishinaabe, essentially, from Yellow Quill First Nation, Treaty 4 territory, Saskatchewan. I identify as queer and two-spirit. I use he and they pronouns. Sometimes I also use she when I am in drag, and my drag persona is Prescription. You can find her on Instagram. I live here in Toronto now and work at the University of Toronto at the Leslie Dan Faculty of Pharmacy. So I am a pharmacist and have been so for 15 years now, and this is into my 10th year as a faculty member. Was previously at the University of Saskatchewan for 6 years, but now here at the University of Toronto the last 3.5 or so. So in my role as an assistant professor, I'm also the Indigenous Engagement Lead for my faculty. A typical week is that it's not typical. Every week is just so different all the time, depending on what the students are currently learning and therefore what I might be currently teaching, what research projects I have going on, conferences, research reviews, you name it. All over the place all the time, which is what I love about it. Knowing that I have this job and that it just is what it needs to be is really exciting.
That sounds like a very ideal work week.
Mm-hmm.
So a bit of a big question, but what inspired you to become a pharmacist and also specifically to work in chronic pain research and experience in Indigenous peoples?
So, although it might be a big question, it's a small answer in that I didn't want to be a pharmacist. How about that, right? So, I was first registered in university to become a high school drama teacher, and life happened. One of the biggest pieces that changed that path for me was that my friends in the education world, they kept asking me, would you like a teaching contract in Saskatoon, which is where I was born and raised? And I said, well, absolutely. And they told me, well, it's going to be really difficult to find a teaching contract right out of school in Saskatoon. You'll probably have to move away for a while and then come back. And I was like, well, that's not happening. I'm not leaving my family, my friends, my life here. So I just dropped all of that and decided to go into like arts and science to plan to apply to medicine. Long story short, didn't apply to medicine at the time, randomly applied to pharmacy because someone told me it was a thing. I didn't even ever consider it. Got into pharmacy, didn't love the first few years of it, ended up applying to medicine, got in, deferred my last year of pharmacy, but then fell in love with pharmacy at the very end of that program. And that was the hospital pharmacy context. So I worked at Regina General Hospital, and I couldn't believe what my life could look like as a pharmacist, and particularly as a hospital pharmacist. And made a big decision. There's a lot more to that story, but ended up sticking with pharmacy and ended up declining medicine, which I had deferred for a year. In my time in the hospital, though, I knew that that's where I wanted to end up. And unfortunately, for folks who are hospitalized, pain is such a common experience, whether it's pre or post surgery or has nothing to do with surgery. And perhaps that's why they are there. Pain is one of the most common reasons for emergency room presentation. Many of those end up being admitted to the hospital too. So it was just unfortunately kind of everywhere in the hospital. Moving forward, as I worked as a pharmacist in various settings, unfortunately, again, every single member of my family except myself lived with, at least for a period of time or forever, or they did live with for a while and are no longer with us, but with chronic pain. And it was so profound that it meant several years of my life were in complete isolation. Absolutely withdrew from society because of the pain of my sister, because of the pain of my mother, and of certainly my other family members experienced pain, but not to the same extent. And in all of that, someone somewhere recommended that I be one of the people on the Canadian Pain Task Force. And I hadn't typically had a pain practice prior to that. Certainly, it was part of my work, but not specialized on pain. And then after being part of the Canadian Pain Task Force, that's when things just kind of went into high gear, and I've been very, very much part of the pain area since then.
Wow, what a story. That sounds like a lot of life experience kind of culminating to your career decisions and that opportunity also to be on the Canadian Pain Task Force, which is a beautiful transition into what I wanted to ask you about next, because I read it. It is a huge body of work and a big accomplishment. For our audience who might not be familiar, can you explain what the Canadian Pain Task Force is and share a bit about your experience on it?
Absolutely. So this was the result of many people's work in advocating for something like this to take place over several years. And when it finally happened, it was an initiative within the major umbrella of Health Canada. So they struck a Canadian Pain Task Force, assigned two co-chairs, and then those co-chairs, along with the staff of Health Canada who were appointed to this work, went on a mission to add six others. So I believe there were eight of us, if I remember correctly, on the task force, including those two co-chairs. And we tried to have a pretty good representation of ethnicity, gender, occupation, geographic location, all of the things to have a as diverse as possible group of eight as we could, recognizing there's a lot more diversity and perspectives that should be added to that conversation. We also had an external advisory panel to just split up across the country of various disciplines, locations, backgrounds, etc. The Canadian Pain Task Force had a 3-year mandate, and within that mandate, we were asked to eventually provide 3 reports. So the first report, these are all publicly available online. The first report was like setting the stage, is where are we at in Canada with respect to pain? And I mean pain prevention, I mean pain diagnosis, pain management, everything related to pain, not just people already living with it. And then the second one, we embarked on a series of essentially research. We had Stats Canada, we had myself and others hold Indigenous talking circles, sharing circles around the country. Some of them had to be, unfortunately, virtual because of the pandemic, but not all were. And we heard from people across the country, people living with pain, families, caregivers of people with pain, healthcare providers, scientists in all walks of life. I'm including even the non-traditional Western disciplines in here too. Like we heard from chiropractors, traditional Chinese medicine practitioners, indigenous healers, medicine people, etc. Then that led to the third and final report, which was an action plan for pain in Canada. That ended with over 150 recommendations for Canada, all levels of government, even right down to practitioners individually, healthcare training programs, pre and post licensure, considerations all across the board of what we all collectively think should be done with respect to pain in Canada. Since that, I'm happy to say that one of those recommendations was to have a dedicated team within Health Canada, and they did that. So there's a chronic pain policy team that has existed essentially ever since the end of the task force. And a lot of programming, bringing people together, think tanks, priority setting have taken place because of that chronic pain policy team and all of the people who are supporting this work. In addition to that, it's not technically part of the task force, nor is it part of the chronic pain policy team, but an arm's length is Pain Canada. So this was another creation that resulted from this work, was to have one central national entity. So formerly and still currently, we have organizations like Pain BC. I'm one of the founding members of Pain Ontario. There's Sask Pain, Pain Alberta, and pain entities across the country. So they all kind of feed into and fall under what is now Pain Canada, which I am a member of the National Advisory Committee. And then there's even some smaller entities with more specific focus areas like Solutions for Kids in Pain, or SKIP. And this is a national focused group that's physically housed at Dalhousie in Halifax, Nova Scotia. And I've been on their board for several years now too. So the Canadian Pain Task Force kind of initiated a whole lot of things happening, and some of those offshoots of things that happened because of it, I remain part of, which is really great.
When I was looking into you, I saw that SKIP, so Solutions for Kids for Pain, may be the only one of its kind, not just in Canada, but in the world.
And I'm happy to share too that an initiative led by the Associate Scientific Director of SKIP, Dr. Katie Burney, who's at the University of Calgary, she led what is the world's first and still only pediatric pain healthcare standards, health standards. So this was in combination with the Health Standards Organization, or HSO, and you can access this online. It's been downloaded in well over 150 countries around the world. And the next phase of that work is to make it become actual standards, like accreditation standards. So where it's existing now, we're kind of saying this is what should happen with respect to pediatric pain, but no one's held to that until it becomes an accreditation standard. And so that's like the next phase of this work. But so SKIP has been busy over the years, including that and many other initiatives.
Yeah, that is so awesome to hear about all the cool things that are happening related to all these conversations you guys started as the Pain Task Force. Honing in on the experiences of Indigenous peoples with pain, we're curious to understand how pain is experienced individually by Indigenous peoples. So from your research or your conversations, are you able to share a bit about that?
Absolutely. And I mean, I'll share a few disclaimers. I know that it's probably obvious, but I think there's benefits in stating the obvious at times, in that I don't speak for all Indigenous peoples. And in the Canadian context, Indigenous peoples is inclusive of First Nations, Métis, and Inuit. And even within some of those groups, particularly the First Nations, there is extraordinary diversity. Like I'm Saulteaux, there's Anishinaabe, Ojibwe, Lakota, Nakota, Dakota, Chippewa, Cherokee, so many kinds of First Nations people, and we all have our own knowledges, systems, practices, ceremonies, everything. So Although I'll be talking about Indigenous peoples, this is a big umbrella term that is in no way representing a monolithic group of people. We are extraordinarily diverse. Having said that, Canada, or what we now call Canada anyway, is a very interesting place. It was violently taken, right, through colonialism. And in many parts of Canada, like even our nation's capital, Ottawa, that was completely unceded land. Often when people talk about a land acknowledgement in the setting of Ottawa, they would mention the unceded traditional territory of the Algonquin and Anishinaabe. But unceded means stolen. So there was never a purchase, there was never an agreement. It was just simply white settlers showed up and said, "This is mine now." And that's a very simple explanation of colonization and colonialism. But so much of what I have to say about pain and so much of what Indigenous peoples have to say about pain honestly traces directly back to colonization and ongoing practices of colonialism. And one of those ongoing practices of colonialism is the epistemic racism, which is racism of knowledge systems that exists within healthcare. So healthcare, by and large, what we see as valid is Western knowledges, right? Western systems, Western ways of conducting and sharing research, Western health disciplines, Western therapies. Many of us are able to access prescription medication, a nurse practitioner, dentist, if you're lucky and have medication insurance for that. But what we don't have coverage for is I can't go see a healer or an elder and get reimbursed. I'm not able to purchase an offering to take to a feast or a sweat lodge and transport there and back and have that covered or reimbursed. So all that to say, this whole system of what we consider to be valid and worthy of reimbursement boils down to colonial thinking. And so that means that Indigenous peoples, we can't even access our own ways that have always been on this land that we now call Canada for millennia, for thousands of years. In this post-colonial era, we can't even access that. So that's brought a lot of collision and clashing in the way that people access or don't access the healthcare system. Anti-Indigenous racism is a very real thing that must be talked about, including interpersonally, but also certainly system-wide, the system treating us differently. All of these things come together to create an experience for Indigenous peoples in the setting of pain that is, in general, worse than non-Indigenous peoples. For pain and several other chronic conditions or even acute conditions, the healthcare system ends up seeing, and then the story ends up becoming that Indigenous folks have worse XYZ. Our pain is worse, our diabetes is worse, whatever you're talking about, it's worse. Well, it's actually not. It starts the same, it presents the same in us as it does anyone else. But because anti-Indigenous racism is so real, healthcare access is so real, geographic dislocation is so real, we often wait. So having access to healthcare, you might feel like, well, that was a really horrible time last time. I'm just not going to go. And then I'm not going to go. I'm not going to go. Okay, well, now it's at a level that's so bad that I don't have any choice. And then when we finally present, especially with pain, you need immediate pain control, which means often opioids. So here you have this Indigenous person who's in pain, which you can't measure, right? Needing opioids. And then the racism is almost even worse than if they didn't wait, you know? So it complicates the experience in so many ways. Even some of our cultures don't have a word for pain. The closest English translation to pain in some nations is hurt. So even just asking a patient, are you experiencing any pain? If English is not their first language and they've lived in this land for time immemorial, that's maybe not the best question we should be asking. Or neuropathic pain, nerve pain, how we describe nerve pain or how we ask patients about their nerve pain. It does not translate very well to many folks, Indigenous or not. But certainly some of the research I'm part of has been figuring out from community what are the best ways, what are the best words that we should use when asking about pain, because that word doesn't even have a translated term in many of our languages. The geographic part is very real too. Much of the interprofessional pain clinics, for example, are not on reserve or in isolated, rural, remote northern communities. So that means travel all the time. I've certainly had people in my life, students in the past, who have talked about, well, why wouldn't someone just move? And there's a big problem with that. The way I shared that back to students was, well, why are you going to this university? Harvard's better. Why don't you just move? then you start thinking about all the reasons why that's not realistic. And so some of those same reasons still apply here. Family. All you know, when you live in your own community, you often don't experience racism because everyone's like you, right? So moving to a city introduces racism to someone's life and their experience. And the list goes on. So the point is that it requires a lot of planning and resources, healthcare literacy, to be able to maneuver through the system that was not designed for or even with or by Indigenous peoples, and then accessing it as an Indigenous person. In some provinces like Saskatchewan, my home province, an example of systemic racism that makes something like pain potentially even worse for Indigenous folks, and in this case, status First Nations and some Inuit. There's something called the Saskatchewan Medication Assessment Program, and this is a provincial initiative because healthcare, by and large, is provincial jurisdiction. And there are certain criteria for people who are eligible to have a comprehensive medication review from a pharmacist that could last up to an hour annually, with around 2 follow-up appointments also annually. So 3 comprehensive appointments with a pharmacist to just sit down, talk about your medication history, what works, what doesn't, your adherence, your blood tests, your immunizations, everything. But if you have a status card, you can't. You cannot have that service in Canada here today, 2025. That program, we promote it so wonderfully well because it's a great program to be able to have a pharmacist review all of your meds with you. But if you have a status card, you can't. It's possible that a pharmacist could still, just out of the kindness of their heart, do so. But unfortunately, my profession, we have a business model that doesn't really allow for that. If they just kept sitting down with folks and not getting any money for it, the business would go under and then they wouldn't be able to help anybody. So there you go. Who you are. If you're a status First Nations person, already there's one example of something that you can't even access no matter where it is. Never mind geography, you're just not eligible. And so that's systemic racism, right? The federal health system, Indigenous Services Canada, the non-insured health benefits program does not have a reimbursement structure for something like a comprehensive medication review from a pharmacist, whereas people in each province who are non-status First Nations do have access to that. So we are unfortunately overrepresented among people living with pain across the country. And then when we do access care, it's often a lower standard than what others get. We're less likely to be prescribed cures for something that might have a cure. We're less likely to be prescribed appropriate pain control. If we are, it's often at a lower dose or administered less. The list goes on like that. And when you add on intersectional identities beyond just your indigeneity, if you're a woman, period, your pain is often appreciated less, believed less, and treated less. If you also have a disability, there's another thing. Sexual and gender identity, perhaps, would introduce another layer of potentially homophobia, transphobia within your healthcare experience. So no one just lives as an Indigenous person, right? There's also other pieces to them. And so that just creates this huge array and variety of experiences. I will finish this whole big thought, though, in that many folks have wonderful experiences, right? And even some of our communities have excellent teams, whether they're always there or they visit occasionally. People don't even have to leave their community to access that care. They might have a pharmacist in or very near their community who provides such services anyway, unlike the other example I mentioned. And so certainly we have really, really wonderful spots and places, and I don't always want to frame us from like a deficit lens, although everything I shared is not a deficit of us, it's a deficit of the system that disproportionately affects us. But I know that Indigenous folks across the country have really stepped up to make things much easier and a better experience for their communities.
If you're comfortable, I'm curious to ask about any personal stories from yourself or maybe your family about the pain experience and its effect on Indigenous peoples relating to navigating all these systemic challenges.
Yeah, so fortunately, I have not had to access care because of pain. Certainly experienced pain in care, like my dental appointments, sure, but I think of people like my sister, my younger sister, Jenna. She, a young Indigenous woman, in Saskatchewan, our health cards, they finally changed this because of activism of my family, my aunties and I and others. But prior, our health cards had a big R imprinted into it, and that R meant registered Indian. So, even if someone didn't visibly identify me or my sister, in this case, in presentation to the ER as, oh, they're First Nations or oh, they're Indigenous, if they didn't know, they would know in the first few seconds of us giving them our health card. And so presenting here as an Indigenous woman in pain, needing pain relief, which again usually means opioids in that acute setting, and then the triage nurse gets to immediately see, oh, they're a registered Indian, that introduces a whole bias into how the triage happens, if it even happens. So my sister unfortunately had to represent so many times. They kept referring her to her family doctor, but her pain was so acute for hours a day, every day, that we couldn't wait like a month to think about developing a plan, right? She couldn't live like that. So we'd be back all the time, and then that triage nurse would say things like, oh, you're back again? Well, there's no cure for what you've got, honey. My sister herself is a registered nurse right now, and she was nearly done nursing school at that time, but even so was treated like that. She was so desperate for care that when we finally got a referral to a neurosurgeon in this one particular example, and my sister just did everything in her power to hold herself together to be able to go through that assessment with that neurosurgeon and respond to his questions. But then his impression of that scenario was he came back to us saying, I noticed that once I started talking to her, she really calmed down and starting to suggest that her pain was maybe catastrophized and not like truly real. So then you kind of feel like, should I just be screaming all the time so that you do believe me? But then if I do that, then am I going to get a proper assessment, or are you even going to want to talk to me at all? And it's just a wild, chaotic event of thoughts and feelings and emotions. One of the times she was hospitalized for several days, receiving opioids and benzodiazepines at doses and frequencies far higher than people in palliative care, and with no pain relief. Clearly, something was happening that was just not working. And by day 5, the physician hadn't even had a chance to speak with her because she was in such incredible pain, or she was completely zonked out with medication. But by day 5, the physician said, I think I'm just going to send her home because I don't think anything's wrong with her. Like, unbelievable. And not just her. And she had a brother who was a pharmacist at that hospital, and, family members with extraordinary health literacy, and access is difficult for us living right there in the city. We had vehicles to use, we had daycare, we had people who could look after our pets if we needed to go to the hospital, all of those things. But that's not a reality for everyone else. So we still had a horrific experience with my sister, especially. Thankfully, she's out of that now, but not everyone has those, opportunities or parts of their lives that make it less horrible.
I'm really sorry that your family went through that. That sounds really extensive. Like it was a long journey. But we really appreciate you sharing that. And it makes me think about the multimodal nature of pain through your story, and then also what I've read in your research. So many things can affect pain. And then for some Indigenous peoples in Canada, that combination of explicit bias, implicit bias, and discrimination can really lead to that exacerbation of pain physically, mentally, spiritually. And I know you've already talked a lot about this stigma, but I'd like to ask you a little bit more about that and how that intersects with the multimodal nature for us as future physiotherapists. Ultimately, same with you as a pharmacist. People are coming to us to treat pain.
I mean, that's also very complicated, this multimodal interventions and what's available and even what's not available. All can be connected to colonialism, coloniality, racism, etc. within the pharmaceutical part. Many, not every single person, but many, if not most, people living with pain use some kind of medication. And the only ones that they might have coverage for would be what the Western system decides is good, and not medicines and practices that have been around far longer than Western medicines. We deem those as not being okay. Some other pieces, like virtual interventions, are a really wonderful thing, regardless of what discipline is sitting behind that virtual intervention. But you can only access it if you have internet, that's affordable, and a device to be able to use that. And in a healthcare interaction, depending what you're talking about or what you want to talk about or what you don't want to talk about, you might not have the privacy around you in order to do that, whether it's counseling, whether it's talking to a physical therapist about your movements, non-movements. If I was living with 12 other people in my household and wanted to tell you that having sex was difficult because of my pain, well, I'm not even going to bring that up, knowing that the rest of my family is going to hear it. So you're not even getting my full story, which connects back to who I am, where I am, and why this is even a problem for me, where it might not be a problem for someone else because of who they are and where they are. So many pieces come into play that affect their care or non-care through so many different angles.
Absolutely, yeah. I'm also curious, you were talking earlier about overprescription of opioids, people leaving their care, like not seeking treatment until a bit later for just a myriad of reasons. As a pharmacist yourself, your bread and butter, your intervention is those medications. And so I'm curious as to your insights on the effects of that overprescription of opioids for Indigenous peoples.
Yeah, we've really been disproportionately impacted by the opioid crisis too, on several fronts, whether it traces back to prescribed opioids or non-prescribed opioids too. There's certainly a lot of trauma, and trauma could and probably even should be part of every response I'm giving here. But independent of pain, someone living with trauma who, for whatever reason, consumes an opioid, sometimes you feel better, right? In that moment. You forget about your trauma, you forget about what's haunting you, what's bothering you every moment of every day, perhaps, and you can just kind of feel normal for a while, even without pain. With pain, well, maybe that experience would be even more profound. Plus, the way that opioids specifically work is they are addictive. For the first several years, unfortunately, that message was not portrayed properly, and pharmacists were part of that misinformation. Mostly because we were told misinformation and then passed it on. We were very much part of that. The rhetoric was, these are non-addictive. There's a difference between addiction and physical dependence, emotional dependence. We had all of these different terms, but they absolutely are addictive. And then to get off of it is so incredibly uncomfortable. So even if I did not have pain, but was taking some level of opioids regularly for some time, if I were to stop, whether that's because I want to stop, or I ran out of supply, or someone is forcing it on me somehow, the experience of withdrawal is so extraordinarily uncomfortable that a person ends up in a position where the only thing they're thinking of is, I need some more because I can't feel like this anymore. So when you do add pain, and their opioids have been treating pain, whether it was wonderfully well, somewhat well, or not well at all, along with those withdrawal symptoms is a drastic increase in pain. So what would you do? What would you seek, right? More opioids. And we control opioids so much, as we should. But in a setting like even my sister, let's say, her pain wasn't just the exact same level of pain every moment of every day, right? Changes all the time. Certainly, if she were to injure herself on top of her baseline pain, then she has an increased level of pain. So all that to say that her use of her as needed pain medication would change from time to time. Sometimes even her regular doses we might need to adjust because the pain got so bad. Then we ran out early, and then you go to the pharmacy, we're out. Well, no, you can't refill it again for another 5 days. It's like, okay, this is medication for me, for my pain, and I'm in so much pain that I used more and now I need it early, and you're withholding that from me. And that absolutely happens. So guess what? I would be the first to admit I'm a pharmacist, a pharmacy prof. I was asking friends, hey, do you know anyone who had their wisdom teeth taken out recently and was prescribed Dilaudid or something? We are so desperate right now, and no one believes my sister. No one wants to give her early refills. So we accessed opioids in another way, right? I can only imagine the alternatives in front of so many other people where that's not even an option. So they would have to go to the literal street, for example. So there's this really violent circle that can happen, whether it was started out with something incredibly legitimate, you had a leg surgery, had a few days of opioids, and then that could turn into a lifelong thing, or it ends after 3 days, right? Or anything in between. Or you just had such horrible trauma and somehow accessed this substance once, and it just made you feel so much better that you wanted to keep using it. But for you to ever stop, it's so uncomfortable that you just keep using it anyway. There are so many different stories in there, of course, but the biggest worry in all of this, one of them anyway, is that fatality is part of this story. You absolutely can overdose and die experiencing opioid toxicity. Even in a setting where someone has been taking regular opioid for whatever reason and then stops, you lose your tolerance to various side effects of the opioids, like respiratory depression. So like your breathing rate goes down a lot when you're on opioids, but then you start to develop a tolerance to that over time. And then if I stop opioids for several days, my tolerance is gone, but I'm so uncomfortable from the withdrawal symptoms that I return to the previous dose I was using, or maybe even more because I'm so uncomfortable. But because I lost all that tolerance, my previous dose, and certainly maybe more, could be enough to lower my respiratory rate so much that I could die. And sometimes like information like that is not appropriately shared with people and families and caregivers, patients themselves, public messaging. Thankfully, we have like naloxone and Narcan to change that, but it also doesn't last forever. If someone gets a dose of naloxone, they still need to go to the hospital because it will not stick around very long. And then we've got even other substances that someone might be thinking that they're using, I don't know, let's say ecstasy, and perhaps their ecstasy has been laced with an opioid, notably fentanyl. Fentanyl's so potent that you only need a tiny little bit to put into a pill or whatever it is that you're buying, selling. And then because there's a little bit of opioid or fentanyl, if I'm a person who's using ecstasy pretty frequently, not knowing that there's fentanyl in it, if I stop using ecstasy, I'm going to be so uncomfortable, right? Because of opioid withdrawal. So I might not even know that there's opioids on board, but now taking more ecstasy could lead to my fatality because of an opioid overdose, perhaps. And it's not like there's good manufacturing practices either in someone who's like making illicit substances in their basement. And there could be just enough in a single pill for some people to die the first and only time they use such a substance. And that's certainly been the story, unfortunately, of many folks I know, including various mothers. They have an organization called Moms Stop the Harm, and you can look them up. But many of these mothers, parents, and families had a kid who just used one thing one time and died from it. So even if I had opioids for my pain, I'm using it wonderfully well. Now my neighbor finds out that I'm in such pain. Hey, this guy must have opioids in his house. There could be a robbing situation. That word gets out that I'm on opioids. How many opioids are left in my house? Are there people, children, visitors, guests who can access it, take it, use it? There's just a lot of opportunity for things to go wrong. But all that to say, opioids are one of our very many tools for pain control, and it's entirely necessary for so many people, and an opioid alone could be the differentiating factor for some people and their families to go back to work or to continue with school or to continue caring for their child, to keep that opioid on board. But there's been such a public narrative on how horrible they are that we tend to limit that, and then that's keeping people not at work, not at school, not able to care for their children. Really complicated. Personalized, patient-centered care, very much required in every scenario.
From our conversation until now, it's just clear that there's an ongoing theme of complex, underlying systemic factors so deep-rooted in a lot of the challenges experienced by Indigenous peoples with pain. So I guess it's no surprise that also that exists in this relationship between opioid overprescription and access to healthcare. Thanks for painting that picture for us and for our listeners.
Yeah, and on that topic of access to healthcare, taking it from even a geographical lens, I'm curious, I was reading in some of your research that a lot of Indigenous communities that are more rural are going to be served by a smaller group of healthcare professionals, mainly physicians. I'm not sure about pharmacists, but I think I'm pretty confident that not as many physiotherapists. And so I'm curious about whether there is a link between opioid prescription and medical intervention versus that kind of allied healthcare intervention, and if there's a space for allied healthcare intervention to kind of help decrease this overprescription.
So even think about it in a totally different context. Like the task at hand in front of us is to build a house, and everyone who's trying to build a house in the city have hammers and nail guns and woodcutters and vehicles and all of these tools in front of them. the way that that looks, the sturdiness of their house, the longevity of that house is going to look very different than someone who's trying to build a house with only a hammer and scissors, right? So that's what happens. Sometimes it's just the physician, sometimes just the physician and nurse. Maybe there's some other discipline who comes once every 3 months for half of a day. Like, it's just not the same. And then when we finally are experiencing a level of pain that's so bad that we end up going to a city or an emergency room needing care, it sometimes gets framed as our fault. Why did you wait so long? Or why haven't you been doing X, Y, Z? Well, because it's not available. Or, there's this assumption sometimes that like we just get everything free and everything paid for. And something like dental care, let's say, yes, is a benefit for people with a status card, but show me where the dentist is on reserve, right? So we might technically have coverage or access to something, but the people who we need it from aren't there. Right before this recording right now, actually, I was on a graduate students committee, a physical therapy graduate student doing a PhD in Saskatchewan, whose entire project is about virtual care and like hybrid models of using like literal robots and whatnot in a northern reserve community, a First Nations community. And so she and the team around her have absolutely invested time and energy, several years for a degree, to be able to study what is the best way for us to do this, right? How can we support something like this? And then what she has already been finding is all of the forest fires that are happening and the forest evacuations. She wasn't even able to go visit the patients because they've all been evacuated. But then I'm thinking, put that into your thesis, right? Because that's another reality of maybe we can't even access any appointment, never mind the specialist. We can't even do anything because we're in some other city in some basement blow up mattress for 3 months, or we just get so disproportionately affected by climate change too, which impacts healthcare utilization or non-utilization. Geographic part, huge problem, and many practitioners don't want to live in such a place because, well, A, that's just maybe not their home, and therefore they don't want to move there. Like, I'm not necessarily faulting people for that, but people do live there, right? And we all signed up to be healthcare providers, and people need healthcare. So how can we share that responsibility and take turns? Maybe if you and 30 other physical therapists all spent one day every month going out to such a community, that community would have a physical therapist every day, but they would only need you, one of those days. So we can absolutely divide and conquer. And I know that many people and places do stuff like that. On the flip side, there's even some downsides to such a thing. You don't get the same longevity with your patient-provider relationship. You're less able to identify like, hey, you're walking differently today. Well, how would you know that when you only see them once every 2 months or something? So just the whole interaction looks very different, even when we do try to solve this geographic problem in ways like what I mentioned. We're getting closer and closer. We're doing better and better. And I think the COVID-19 pandemic really accelerated a lot of our efforts and made care more accessible, like with some of these robots and even, quite honestly, a Zoom appointment. You would all know better than I that you can absolutely model a movement, a stretch for me, watching you on Zoom, and then I do it too, and you can correct me in real time on what I'm doing, right? But before, when we didn't have such software, you couldn't really do that over a telephone or through a letter. So things got better quickly and worse simultaneously with the pandemic. But I think by and large, we are doing better with respect to this unfortunate reality of geographic location.
You did bring up some challenges for accessing healthcare virtually for Indigenous peoples earlier. So I guess I'm curious to, just in the overall scheme of how are things still the same, how are things still lacking, and how are things improving in the context of, okay, where are we starting to see things change? Where are we seeing hope for Indigenous peoples and their healthcare experiences? With that, do you have anything to say?
So again, the whole range of realities, from some of the most innovative, technologically advanced opportunities in some communities to some not having water that's safe enough to even bathe in, right? And everything in between. So it's hard to give like a single answer here, but some of the things that are changing is that we do have more opportunities for virtual care. More providers are providing such a thing. Family doctors, physical therapists, pharmacists, like lots of folks are offering such programs. Many of the programs and software that abides by all of our ethical and legal responsibilities of confidentiality and all of the things require current operating systems on newer devices. So let's say Community X, half of them have an iPhone. It might be the iPhone 7, which doesn't support the iOS software that's required to support the software for the physical therapist to talk to them, right? So sure, they might have a device, but there's still limiting factors there. Even if they had the right device, internet access is out of this world expensive for very, very slow, imperfect internet. Then the privacy considerations I was thinking about too. Do you have a spot to even use the virtual options? The robots are what we have now in a bigger way that we didn't before, and that PhD student I mentioned briefly before is working with that too. So quite literally, you as a physical therapist sitting in even your house in Toronto could drive this like robot throughout the clinic, wherever it is, and see like what the robot sees, and then they would see like your head would be on this robot, and you can do various assessments that way, and they could still be at the clinic in a private room with you even though you're not physically there, and that patient doesn't need to have their own internet and device because they can just go to the clinic and still access you even though you're not there, right? So we didn't have stuff like that before. So this is really helping a lot of people. And PhD student I mentioned, she's worked alongside community at every step of the way. It wasn't just a, hey, here's a robot, let's see what it's like. It was, hey, this technology exists. Do you even want such a thing? Let's meet about it several times. What concerns do you have about having a robot in your community? How can we tackle those concerns? What opportunities are here? They did a lot of planning. They haven't even brought that robot in yet to that particular community. And then working through it together. So it's not just bam, here's this thing in front of you that might be really scary. So we can do that. Nothing's stopping, folks from doing that. Money is required for that particular robot, but so does everything else. Everything else costs money too. And when we think about equity in healthcare, who's far overrepresented in such a setting and disease state, while simultaneously being among the least served, right? So even if it does cost money, great, put it there. Right? Let's address this equity concern here through that way. So lots is getting better. I don't know if stuff is technically getting worse, but a lot is also still the same. And I think that was your question. What stayed the same? What's got worse? What's got better?
So from what you found in your research, your work with the Canadian Pain Task Force, all these roles, you've clearly gotten a strong sense of a lot of those gaps and challenges our healthcare system needs to keep working on. So I guess for those of us listening as individual practitioners, especially as physiotherapists now, it can be tempting, just reflecting on how I'm feeling, to get overwhelmed and want to sometimes respond to that with inaction. So instead, I want to move us into some of those tangible ways of thinking and doing that we can embrace as individual practitioners. So moving that conversation to what are ways in which we as individual practitioners can actually start to practice culturally sensitive care? Do you have thoughts to open up that conversation?
I see many areas here, but I'll boil them down to pre and post licensure. On the pre-licensure end, whether you're a student or already licensed, advocate for this content to be a huge part of the curricula, because it wouldn't feel the feelings you just described of feeling like overwhelmed by everything you just heard in this call. None of it would have been new information if you learned about it in school, right? Over several lectures. If I was the first person right now to be talking to you about complex regional pain syndrome, CRIPS, you might be like, okay, whoa, this is a lot, right? But maybe it's not overwhelming because you had lectures on it. So it needs to be taught. It needs to be taught correctly. It needs to be taught well, and it needs to be assessed well too. Not just like a 1 hour guest lecture. Here's some interesting information, or maybe 2 1-hour guest lectures, then people don't place the same value on it if it's not tested in the same way everything else is tested. Do you have skills labs where you are working with actual Indigenous patients, even if they're actors? But even the actors, the standardized patient programs in many universities don't have any Indigenous actors. So if or when that happens, there's non-Indigenous people playing an Indigenous patient in a lab that's supposed to be about working with Indigenous patients, which is just maybe creating more harm, right? So advocate for recruiting Indigenous actors in your standardized patient program at your respective universities. The curriculum, the practice experience, the possible placement sites where you work, having some mandated frequency, like let's say you all have 30 weeks that you need to do. Well, what if every physio student had 2 weeks in a northern, rural, or remote location? Every single one. You can't even get the degree if you don't do that. Then there'd be no fear of the unknown. There would be no sense of overwhelming, of I don't even know where to begin, because you already did begin. You had 2 weeks there, or whatever other duration of time could be decided. So a lot can change. What if we didn't even teach low back pain to physical therapy students? You would now go into the world, be like, this is a huge thing. Well, guess what? We've been doing that with Indigenous peoples. Sometimes it's not even in the curricula, and then we expect you to graduate and go work wonderfully well and efficiently with Indigenous peoples who are vastly overrepresented in this space, but no one prepared you for it. For you as individual practitioners and students, advocate, 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 advocate. Write letters. Sometimes I even tell folks, like, never underestimate the power you have, no matter who you are. Can you imagine if you organized a massive walkout of physical therapy students in every program in Canada? We are not going back to school until you include XYZ in our program. Or what if every practicing physical therapist says, I am not showing up to work until A, every Indigenous community has water, and B, that we have some mandatory minimum level of competency standards in our profession for working with Indigenous peoples. That would happen so fast. And even if it didn't happen so fast, it would initiate a national imperative conversation. So again, not saying go do that, but you could. On the post-licensure side, like any other topic, there's a lot of self-directed learning that has to happen. Some of that doesn't always have to be self-directed. So, the mandatory minimum education standards that might be required, whether it's every year, every section of years in your discipline, there could be some proportion of that learning that needs to be Indigenous related. So what if like 20% of your continuing education credits every year or every 5 years or something need to have an Indigenous component or Northern Rural Remote Reserve component to it? Then you're ensuring that everyone's keeping up to date and hearing the stories that need to be heard, right? Similarly, the walkout example, that could be there to force some change to happen really quickly. Hear people's stories, and there are so many stories captured in so many ways, whether it's a book, fiction or not fiction, YouTube videos, pain advocates, people with lived and living experience on social media. Follow them, listen to their stories, like invite someone to your house, to your clinic, and pay them for that if you're accessing their stories. How could you move forward in anything without doing any of that, right? Like pretend you never did learn low back pain and now you're in practice thinking, oh my gosh, so many people have lower back pain. What would you do? I would turn that question right back to every listener. What would you do? Apply that same process and thinking to Indigenous people's health and Indigenous people's living with pain. Identify resources, ask questions, do some searches, look at the Canadian Pain Task Force. Maybe you identify some Indigenous pain organizations like the Aboriginal Child Hurt and Healing Initiative in Halifax, Nova Scotia. Check them out. And even if it's not about children, well, maybe they know someone else in the Indigenous pain world to refer you to, right? There's no shortage of information or people out there, but there certainly, unfortunately, has been a shortage of those ensuring that everyone gets access to those people and that information.
Something that really resonated with me with what you just said was about accessing people's stories and, trying to put all these things together in some of your research, specifically on treating MSK pain in Indigenous peoples. I saw that you went into a Northern Saskatchewan community and you did a community needs assessment. And then somewhere else, I saw that ultimately we need to know our individual patient's story in order to really effectively manage their pain, to get a comprehensive pain assessment for a variety of factors. And so I was wondering if you could just elaborate on that a little bit more, explain the value of us as healthcare practitioners doing that kind of comprehensive pain assessment that includes asking about someone's lived individual stories.
Yeah, I'll use like a flipped parallel type of story to emphasize my point, which I often do. Sometimes they might sound or come off as cynical, and I don't mean it for it to be that way, but it seems to really emphasize the point. So, like, let's say you and your family, let's pretend you live in a house with 5 relatives, parents, siblings, aunties, uncles, something. And I know that one or several of you have pain. Meanwhile, I'm over here doing my thing, and then one day I come to your door and I'm like, hey, I have this program just for you. And here it is. He'd be like, okay, who are you? What program do you have? Do you even know which of us have pain and the nature of our pain? Like, it's just kind of wild how many things get developed for Indigenous peoples without any engagement with them. And we don't apply that thinking elsewhere. It's like, it makes no sense to me. So always with, by, and for, never just for Indigenous peoples. So yeah, a needs assessment, and that needs assessment could be done in a way that is familiar. So let's say you and your family every Sunday night have a family dinner, and the people who don't already live in that house come over to your house, and maybe they each bring a dish, and you have dinner and you chat and you stay a few hours after dinner just talking. That's a familiar scenario for you. So if I want to hear from all of you, I should come there with a dish and eat dinner with you and stay talking for hours later as well. I'm not asking you to show up somewhere else that you don't normally go. I'm not asking you to do something in a different way that you haven't normally done. I'm not asking you to fill out some survey or here's some kind of scary Zoom call of me, the professor in Toronto, and I'm asking you all these questions. It's just this power differential. So for many, if not most Indigenous folks, a needs assessment would be like a community sharing circle or talking circle, something that they already do. They've been doing since kindergarten, maybe even before kindergarten. It's a familiar way of having conversations. Even when I do other research that's more like one-on-one within Indigenous research methodologies, something that you might typically perceive to be an interview, we call it the conversational method. And I have a lot to say about all the different Indigenous methodologies, but I use that in my own PhD, the conversational method. Someone who doesn't understand Indigenous methodologies would think that I did interviews, and I guess I technically did. But what qualifies it to be an Indigenous methodology is it was all coming from an Indigenous paradigm, an Indigenous worldview. I understood reciprocity. I understood that I was as much part of that interaction as they were, right? We have this very wrong, in my opinion, understanding that in other research, you as the researcher are just kind of like this omnipresent being with like no bias. You design the questions, right? Like it's incredibly biased towards you and your worldview and what you think should be asked and shouldn't ask. There's tons of bias anyway, but often in a typical research interview, it's here's my question, here's the next question, here's the next question, and the person leaves without even maybe remembering your name, or like, do you have siblings? Do you have a dog? What's your favorite color? They're going to respond to all of those questions very differently if they do know all of those things. We tend to teach people in Western training programs of like first name only, right? Like you're Jaris, the pharmacist. People don't need to know where you live. They don't need to know who your parents and siblings are, if you even have parents and siblings. But then in the Indigenous world, it's all of those things need to happen for me to be effective in this particular setting. So a needs assessment, yeah, let's chat with the folks who this is supposed to be for before you even get any further at all. Like don't do anything. Once you've identified, hey, maybe we can make pain care better for folks living in Reserve X, stop there, go to Reserve X, have conversations and let the rest of it come from them, like co-developed. We've had far too much of a history in this country of things being done for Indigenous peoples, even if they're well-intentioned, but it doesn't always work out as well.
Yeah, that analogy and those thoughts are just so helpful for pointing out the somewhat tone-deaf approach I think we can sometimes default to in healthcare. And you've talked about the importance of giving the stage to Indigenous peoples living with pain for us as practitioners with tangible ideas like inviting them to share their stories and just giving honorariums for that too. To me, that ties back to that overall idea of embracing cultural humility in our care. I was wondering if you have any ideas for how that should influence us in real-time assessment and treatment as physiotherapists, even say when an Indigenous patient comes to our clinic today or tomorrow.
Yep. So not a new concept for, I think, anyone, unless you've lived your whole life alone in your home without stepping outside. So you've probably walked into a friend's house for the first time or 100th time and thought things like, should I take my hat off? Is it okay that I leave my hat on? Where should I leave my shoes? Should my elbows be on the table? What are other people doing? Like, you're approaching that family, that house, wherever you are, with humility of like, there's probably stuff I don't know here. So how am I going to know it? Observation, asking questions. Maybe you read up. Maybe this family whose house you're going to lives a really traditional culture X lifestyle. So go read up on that culture and, have some kind of foundation of understanding whether or not it applies to that particular household and family. Who knows? But now you have some baseline of it could have applied to them, or maybe it'll apply to someone else, right? None of that learning would go to waste. So we're all very familiar with humility. I think that we enter many phases of our lives, whether they're over periods of time or in an instant of like going into someone's house with humility. So draw on what you already know, right? You all have humility. So ask questions. Sometimes folks even write down to a land acknowledgement. They'll either not do it or they'll do it in a way that you can tell they feel so uncomfortable or that they don't know how to pronounce the names. But then I always tell folks, say that. Say, I'm really uncomfortable sharing this land acknowledgement. And as I thought about my uncomfortability, all these other thoughts came into mind. Why am I so uncomfortable? Maybe it's because I've had really limited exposure here. Whose fault is that? Maybe some of that's my fault. Maybe some of that's my K-12 education. Maybe some of that's my physical therapy education. Why don't I know how to pronounce the names of the first people whose land I'm on? Some of that could be my fault. Some of that's a lot of other people's fault. What's going on in your mind? Say it. That's humility. Say it. I could be doing something totally wrong right now. Please let me know. Please interrupt and try your hardest to approach feedback from like a productive sense. Sometimes I'm guilty of this too. Someone will say something to me and my immediate response will be an explanation for why I did it that way. Oh yeah, that's because this happened earlier and blah, blah, blah. Just leave it. Cool. Thanks for letting me know. Yes, great point. Don't create like a offensive, and I don't mean like as in offending someone, but like offense, defense type of dialogue of this person giving feedback and this person fighting back with a reason for why they're actually right, or just leave it. Like, oh, hey, we actually take our shoes off in this house. Oh, thank you so much, period. Versus, oh, I haven't done that in anyone else's house. Giving a whole story. So just go with the flow, and share your internal dialogue. That's maybe my most common feedback. That will help you in everything. With a partner, with a friend, with a patient, with a provider. Say, I'm really uncomfortable right now. Or, geez, I came here with a lot of excitement and I feel kind of deflated. Talk about it. Because whatever is going on in here is preventing you from fully participating in the present. Whether you're giving the information or you're receiving the information, something's going to block you from fully gathering all of that. So spill it out so it can be addressed. That's all part of humility, knowing that you just don't have all the answers and you not even knowing if there's an answer to be had, right? Not knowing what you don't know and being totally okay with that.
That's really helpful for me. You're right. We already know about humility. So to call it that that's not a new thing, it makes me think of what if we all, as practitioners, just treated the experience of a patient coming into our clinic as me entering into their home, me entering into their pain experience, and the humility that's warranted there. It's such a thing to be vigilant against coming at them as the expert in the room. So that really gives me some food for thought. I think we're going to start getting into some of those wrap-up questions now. One last one for me. For all of the future and current physios out there listening, what is one take-home message out of all the things that we've talked about today that you want to give when just treating Indigenous clients with chronic pain?
Always stay curious, because when you're curious, your heart and your mind together will lead you to where you need to go. Stay curious. Things are always changing. Once you've learned something, it's not just in the bag, you're done. Everything you know about pain, everything I know about medication changes constantly. Same thing as working with Indigenous peoples, who we are, who we continue to evolve to be. Stay curious, and then both your heart and mind will take you to where you need to go.
Thank you so much for joining us today. This has been so incredibly rich, and I think will really help shape ours for sure, and a lot of our listeners' lens going forward as practitioners. So I just have a few conclusionary questions here, just to get to know you a little bit better. We know that you have your fingers in lots and lots of pies. So just a question, what is something exciting you are working on for the next while?
My most exciting thing, which I kind of name dropped at the beginning, is my drag. So, Prescription, or Miss Priss, or just Priss, or whatever you want to call her. Her first big major debut is going to be at the International Symposium for Pediatric Pain in Glasgow next month, middle of June. And I'm holding a panel. It was supposed to be like a regular academic panel of 4 academics who each get 15 minutes to talk about their topic, and then there's an extra 15 minutes for Q&A with the audience. So I just said, can I have those 75 minutes, but make it a talk show hosted by me? So it's called Pain and Pride, hosted by Prescription. And I've got researchers and pain practitioners from Sydney, Australia, Stanford University, University of British Columbia, and myself on this panel. So I'm the interviewer, but also have stuff to say, when I have the floor. And each of them will be there. I'm going to make it fun and engaging, have like applause signs and like gasp, like audibly gasp, or get the audience super engaged. I know that in conferences and lecture halls, people get distracted. Me too. My phone is out sometimes. Some students are shopping. I think that people will be fully engaged in this type of situation. And that's one of the major goals of PRIS existing, engagement, because now that you're engaged, you're hearing everything I have to say. You're not going to miss something here, and I have important things to say. So people are going to hear it and they'll remember it and they'll pass it on, I hope. Then that evening, I'll be hosting the traditional Scottish Ceilidh party for this global pediatric pain conference and a few lip sync numbers. I am going to encourage folks to tip the queen, myself, but Pris will never keep tips for herself. All of my tips will go toward pediatric pain research. And then the few times in between when I'm introducing like the next act or the band or whatever, people are going to hear what I have to say again about gender and sexual difference in that particular context of pediatric pain. Because so many of these folks wouldn't just go to a drag show on their own. Maybe many of them will, but I've invented Pris, I've created Pris to bring what she has to say, to bring drag, to bring gender and sexual difference to people and places and conferences, quite literally, where such folks wouldn't otherwise be receiving this message at all, or not in this way, and maybe even some secondary endpoint to Pris's mission is like bashing homophobia, transphobia. Perhaps they've seen a pharmacist and professor, University of Toronto, in drag doing this. No, there's not something wrong with me. No, I'm not a pedophile for reading books to children. Here I am, a scientist, a trained researcher, and I have something to say in a dress and a beautiful wig and makeup. So there's a lot working here. Similarly, Pris is going to be working with the chronic pain clinic at Sick Kids, doing drag story time. And I see it as a therapeutic intervention. So I'm doing pain assessments pre and post drag story time. Some of the stories will have elements of pain in them, which might initiate some conversation among the children and their caregivers, parents, family members, friends. I will survey them and their family members, caregivers, friends too about that experience. And then after all of that, I'll be hanging around with them as Pris, who's a registered pharmacist, and I can answer their questions about their pain medication. If their parents have questions about their pain medication, I have a license behind me, versus a different drag artist who is so wonderful, but not also a licensed pharmacist, right? That would have to be someone else coming into the picture. So I'm trying to tackle the scariness and the hierarchy that often exists in healthcare by clowning it up, making it like a Disney princess moment versus the pharmacist in a white coat behind a counter that you're separated from. It's a form of decolonizing, right? And decolonizing doesn't always have an Indigenous connection. It means challenging those central assumptions of domination and patriarchy and ethnocentrism that exist in our system and breaking down barriers and breaking down hierarchy. That's my most exciting thing these days.
That is so exciting. I have to admit, I did see Prescription's Instagram debut a few weeks ago. And I was like, Prescription, cool, beautiful. And then I was telling Tiffany and Rebecca about it. And that's when it clicked that it was Prescription. But I think that's honestly just me.
Yeah, that's happened a lot. People are like, where are you, Prescription? I'm like, what? No. Prescription. And then they read it and don't think anything of it until they say it. And then they're like, whoa, I just said the word prescription. Yeah.
You're a pharmacist. That's so funny. Just a follow-up question to that. I remember when I had come and talked to you after your lecture a few months ago, and you had said that you were going to sit kids in drag. And forgive me if I'm remembering incorrectly, but I think you had said as a form of distraction therapy for the kids. And so I was wondering, like, in terms of Miss Priss's mission with pain management in kids, we're nearing the end, but quickly, like, what?
That has been around forever, right? Not inventing anything new there. In fact, I'm not really doing anything new in all of this. Just kind of mixing what has already been done and using it in different ways, maybe. But yeah, distraction is a well-studied, well-known technique for pain management. And so this is quite distracting. A pharmacist, professor, person in drag doing whatever I'm doing, right? Sometimes if that concept feels really wild, hard to picture in people's minds, I remind them that we have training programs, we have job vacancies, we have people in the jobs of art therapy, music therapy. What's so different about drag therapy, right? I'm kind of combining art therapy, maybe some music therapy in there, and distraction. This is therapy. It's therapeutic. Drag is therapeutic for me too. The act of doing that is healing for me. Never mind the recipients of it for a moment. And I think, and eventually I'll get there, but the effect or the magnitude of effect, and I think that there will be an effect versus no effect, I think that magnitude of effect will be even more profound in children who identify themselves as gender or sexually diverse, or who have gender or sexually diverse people close to them, sibling, parent, or something. You know, maybe this child who is cis and hetero has two dads, and the fact that their home life is now represented in front of them in a healthcare setting by a healthcare provider, I think that's going to mean something to them. We do a pretty good job for most of the population, but the spots where we don't do as good of a job always is where Priss is going to be. The gender and sexually diverse area, Indigenous area, because she is a two-spirit Indigenous queen, and that's where I'm focusing. The rest of my, colleagues and other people can go do whatever they're doing, and I'm going to focus on this one area. And, I felt a little bit embarrassed. I still often feel embarrassed. It's something I have to work through, in that some of my colleagues are doing like life-saving interventions and like curing metastatic brain cancer. And then I present right after them, and I'm like, here I am in makeup and a dress. And I felt like, oh my gosh, my colleagues and other people are doing like all these like life-saving research and interventions, and people really close to me around me said, Jaris, this is life-saving too. And I said, you know what? You are right. Because the level of depression, anxiety that can result of being a gender or sexually diverse person in this world can be so severe that people do have suicidal ideation and or attempts and or completion. So if they start seeing this quite dramatic difference in front of them in a healthcare setting, right? It's not something that they signed up to go do extra. They're going to the pain clinic, and this is what they're getting. They didn't choose to go to a drag show and buy a ticket. It's coming to them. I think it will just shake things up a bit and show that we celebrate this difference, and maybe these kids don't have to hide, because there's also a lot of connection between suppressing your identity and your experience of pain. Even if it's physical somatic pain, if you are working on suppressing who you are constantly all the time, your cortisol, your everything is just on fire, right? And no one part of you exists in isolation of the other. So if I can help contribute to some of the, relief of anxiety about people being who they are in the setting of pain or whatever other disease state we're looking at, then Priss has done her job.
Well, thank you so much for joining us, for taking the time, for telling us about all of your endeavors. I think we're all very excited to see where both you and Miss Priss go in the next few years, and also for speaking about Indigenous experience in pain. We were talking about lack of education, and this podcast and you really taking the time to do this hopefully will bridge some of that gap for some of our physio students and practitioners. So really, we are just so sincerely grateful to you for that and for your work.
Thank you. Yes, thanks for having this. Like, you're filling in several gaps, but can you imagine if you didn't even need to have a podcast, and if you didn't even need to have a podcast on this topic? So there's some answers for people right there.
Thank you for listening to this episode, where we heard about Dr. Swidrovich's professional and personal insights on the factors affecting chronic pain experiences of Indigenous peoples in Canada. If you want to read more on this topic, we've included a link tree in the show notes. Paincast is a freely available resource for you to advance your knowledge about pain and physiotherapy. We will continue to provide you with top-notch, evidence-based, practically oriented content.
To help more people know about this amazing resource, follow us, rate us, and share our content with your network. You can follow us on Instagram at the handle paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.